Well, welcome everyone, and I'm gonna kick it over to Jillian.
Great. Okay, so thanks folks for joining the Duke-Margolis Open House. And so just want to give a little bit of introduction about the center and then really turn it over to the panelists and Sarah to kind of go through some of their trajectories and then kind of some more of the different opportunities of ways you can get involved with the center. But so Risha, if you could go to the next slide. Before I dive into the overview, just a little background on who I am. So I am Jillian Saunders Schmidler. I am a professor of population health sciences, and I'm deputy director of academics for the Duke-Margolis Center for Health Policy. And so the center, as is shown here, it was established in January 2016 with a gift from one of our Duke alumni, Bob Margolis and his wife, Lisa, through their foundation. And the center really integrates the Duke University scholars and their academic health system with research staff and faculty looking to bring together policy and research together. And so I think if you go to the next slide, has a little bit more about our mission and our vision. So the mission of the center is to improve health and the value of healthcare through practical, innovative, and evidence-based policy solutions. And actually, one of our recent changes as our mission statement, actually, we're changing it to be improve health, health equity, and the value of healthcare through practical, innovative, and evidence-based policy solutions. But really how we're doing this is through interdisciplinary academic research and then education, and doing it in ways to inform policy. And so the center, before we move on from here, the center, how it's set up is it's actually, we have 2 physical locations, or, right now we have, 100 different locations all over in terms of the remote working, but normally we have a physical presence on Duke campus, and we're based in the JB Duke over near Fuqua. And then we have also a DC office up in Washington, DC, right on Pennsylvania Avenue. And so the faculty that are associated with the center are from all over campus. We have about 50 different faculty that are core to the center that are, housed either within the School of Medicine, law, policy, nursing, engineering, business, Trinity, so all over. And then we have research staff and students that are also across the different disciplines. We have the group here on campus, and then we have about 50, or I guess maybe 40 research staff up in our DC office as well. And so you're actually today going to hear from people that are from the different parts of Margolis. And so if you go to the next slide on the panelists, we have 4 panelists that are going to kind of provide some different perspectives about working with the center and their kind of research that they do. We have Nathan Boucher and Nina Sperber, who are 2 of our core faculty members. Nathan is based within the Sanford School of Policy and also the Durham VA. And then Nina Sperber is based also within the Durham VA and then the Department of Population Health Sciences over in the School of Medicine. We then have Will Blesser, who's one of our senior research staff based up in Washington, DC. And so he can be kind of talking about things both from that perspective, but works very closely with faculty and students and staff down in our Durham location as well. And then we have Dana Guggenheim, who is one of our existing Margolis scholars, and then also a previous Margolis summer intern, who can also provide a perspective from that point of view. And so really today, I'm going to turn it over to the 4 panelists to let them talk to you, and then have Sarah give you some more information about some of the different programs that we have within the center and ways that students can get involved with the center either throughout the academic year or during the summer or past graduation. But then certainly welcome any additional questions from folks either during this time or else, reaching out afterwards, and Sarah can share some information on how to get in touch with folks after. So going to turn it over to our panelists and let us know how we can help.
All right. So I should just jump in then, right?
Yeah.
Great. And so I'm including my email address in the chat, and so feel free to follow up with me at any time. Just got a few moments to to talk about some stuff here. So I've been in healthcare delivery in various administrative, clinical, educational, and research capacities for about 20, going on 26 years, and a bunch of different states. And but right now, what I do is focus on health services research and teaching. I don't work clinically anymore. The areas that I focus on right now are in caregiver support in the context of advanced stage illness, sometimes palliative care and end-of-life care, hospice, but certainly serious illness and the caregiver issues related to that. And when I say caregiver, I specifically mean the informal, unpaid family or friend caregiver, rather than say the, a professional licensed, clinical staff. Although that's an interest of mine as well when it comes to caring for folks with advanced illness. So, so I do focus on that research area, both federally funded, but also have projects going in on the Duke side, or that I'm working on the Duke side. And so I wear several different hats across Duke and Margolis and the Stanford School of Public Policy, the School of Medicine, as well as the VA. I'll keep it short and sweet. I'll stop there. Maybe it wasn't sweet.
Yeah, thanks, Nathan. No problem. We'll click on over to Nina, and we'll take questions for you at the in the bigger Q&A. Sounds good.
Okay, thanks. I'm gonna try my video for a minute here. It was acting wonky on my last Zoom, but so I'm Nina Skerber, and like Nathan, I'm a health services researcher, and in my work, I really focus. I do have these content areas that I've indicated at the bottom of the slide here, but really, I like to describe my work in more kind of transferable terms. So I focused on evaluating use of new evidence-based processes or tools in healthcare systems to identify facilitators and barriers to use and ways to improve uptake. And so, as Jillian mentioned, I have two positions. I work with the Durham VA healthcare system, and also in a research center, and then also have an academic appointment with Duke Department of Population Health Sciences as an assistant professor. And so I really have found and believe that the VA is a very interesting place to do health services research. It's the nation's largest healthcare system, and I have found that in many ways it's like a lab for U.S. healthcare, and that it's federated. So there's a national or central office, which is like the federal level, and then there are regional networks, which are like state level government, and then local medical facilities and clinics. And so it's a really interesting place to study kind of rollout of national programs and policies, and then how they're put into play at regional or local levels. So I did not set out to do health services research. I really didn't know what it was until after I finished my PhD program. I initially studied anthropology, and then after my studies, worked in market research, where I used qualitative methods to understand how humans interact with products, and then make recommendations to companies, which included very large, Fortune 500 companies. And so, in that work, I primarily used ethnographic methods, observing consumers using products like daily shower cleaners in their homes or workplaces, and interviewed them and made recommendations to product developers and brand managers. But it was fun and interesting for a little while, and then I really decided that I wanted to do something that was more service oriented, and was really interested in public health, started learning about that as an option. So then I ended up working as a research assistant in California at UCSF, and then Stanford. And then after that, decided that I wanted to learn about quantitative methods, and that's what led me to get a PhD. And really the reason I wanted to learn about quantitative methods was not to actually do quantitative research myself, but really to be able to work with other people in a multidisciplinary setting. But I actually found that I really enjoyed quantitative methods, and surprisingly, so I I actually pursued a PhD at the School of Public Health at UNC Chapel Hill, and in the Department of Health Behavior. And so I guess, just that I entered the program, like the program that had the least intensive, I guess, requirements for quantitative methods, but I ended up taking courses in other departments like biostats and epidemiology and so forth, and was able to really build my toolbox that way. So I don't know how much time I have left because I do not have my phone with me, but basically I ended up gaining a solid understanding of quantitative methods from my studies and really learning about research design. I felt like I was in a really good program for that. And so after graduating, that's when I obtained a postdoc position through Duke and the Durham VA, and that's where I learned about health services research. And that's what I've been doing since. That was about 10 years ago or so. And it really ended up being a good fit for me. In hindsight, I was always interested in this interplay between national and regional or local delivery of healthcare innovations through health systems. And so, although I primarily still use qualitative methods when I do work myself, for my training in anthropology and then applying what I used in my market research work, I do collaborate on projects that involve quantitative methods, and I help to design studies where we integrate quantitative and qualitative methods for what's called mixed methods research. And so just as an example of some projects that I'm working on now, one is to evaluate implementation of a new program that provides tests of genes that are known to interact with certain drugs and in turn affect how people react. So it's pharmacogenomics. The VA is implementing the largest pharmacogenomics program at the moment. And so, and this information can help providers ultimately to more precisely target drug prescribing for patients. So I'm involved with a team to evaluate the implementation of that program. In my Duke work, I'm starting to get involved in research that seeks to understand how to get healthcare systems and healthcare providers to use clinical decision support tools. So these are health information technology tools that analyze data from electronic health records, and, big data, and then help clinicians make sense of the data and be able to use it to make just-in-time decisions. So I'm helping a team to evaluate the implementation and improve use of those kinds of tools in Duke and in other settings. And then also, interestingly, I'm starting to, in the VA side, again, I'm starting to work on a really rapid turnaround project that's really driven by operations and policy leaders to understand healthcare providers' attitudes toward the COVID vaccine to help with the rollout. So that's an example of like applied research within the VA healthcare system that's really, directly going to affect policy and programming in a very short amount of time. So I don't know how I'm doing with time, but in a nutshell, that is my trajectory and what I do right now.
Yeah, no, thank you, Nina. We will definitely circle back. I think we've got plenty of questions on that.
I accidentally left my cell phone at home, so I feel a little bit of a loss there, but I think I can function without it.
Yeah, no problem. All right, I believe Will, you're up next.
Thanks, Sarah. So hey everybody, my name is Will Blesser. I'm a managing associate with the Margolis Center in the DC office, and essentially what that means, as Jillian was saying, I'm part of the senior staff responsible for both researching, designing research projects, some management of staff, and developing a broader portfolio of research. My path, like Nina's, but maybe a little bit more within related fields, has winded a little bit, which I think is common and would just emphasize for others that it's totally fine for your career to change multiple times. I started out in public health. I guess you could say I'm in about year 10 of my work experience, including my doctoral degree, since there was, you're working half-time during that period. But I started in public health. I did my master's at the School of Public Health at Hopkins, and I started kind of like specific, and my career has gotten a little bit broader and shifted over time, and I'll talk about what that means. But I started out in the international health world, and I was doing a lot of research on vaccination specifically. So I was trying to understand vaccination policy, vaccination from a health services research standpoint. So, who's receiving it, who's not, and why. And I continued to focus on that through my doctoral degree and through a fellowship that I did before that. So I worked for the U.S. Department of Health and Human Services for 1 year in a fellowship at the National Vaccine Program Office, which was really a policy-focused position, helping to run a national advisory committee that essentially addresses issues with the U.S.'s vaccine plan broadly and coordinates all the agencies. But that was really around vaccine safety and helping to get adult vaccination rates higher. And as I was sort of, thinking about what my next steps were, I mentioned I had this degree in international health. But one of the big takeaways I took from that degree was, if you look at the public health statistics of the United States, we're actually ranked about in the middle of all countries internationally, and certainly well below all of our comparator nations in the developed world setting. So we have a unique set of problems here that, frankly, a lot of low and middle income countries in the international health field are also struggling with. So I took that, sort of spirit and said, let's try to fix all the problems we have at home. I pursued a doctoral degree in health services research through the Department of Health Policy at Penn State, and it was also a joint program in demography, so a population health focus as well. And I started broadening my sort of vaccine focus a little bit to be more on preventive health equity and the policy levers that are able to affect that. What can the federal government do? What can the state government do? What can organizations do? And that continued to get broader. I started doing work while still at Penn State on broader health policy levers. So transforming the system as a whole, not just related to vaccination. What are the legal and regulatory ways you can do that? How did the Affordable Care Act do it? What are the mechanisms that the Affordable Care Act created? How can they be fine-tuned? What are the problems in implementing those policies and any other implications that come up when you're trying to figure out how to do that? So that focus there is what became the bulk of my work here at Margolis. Again, I say broader in the sense that we're talking about larger, more system level mechanisms. But my interest in health equity, which has been there since the beginning, is now really for the past couple of years been overlapping with our center's work in what we call healthcare transformation or payment and delivery system reform. So, how do you change at the highest possible level how you pay for healthcare, how doctors are paid, how you oversee what they're doing to both offer greater flexibility in what they can do, but also holding them to a higher standard of quality of care and of how much money they're spending to make sure that you're only getting higher value care. So there's a lot happening in this space right now where all of my background has sort of been coming together in addressing social needs and health equity through these system level payment and delivery mechanisms. And I'll just briefly talk about what's happening in North Carolina right now, because it's actually sort of the all eyes on one state is the way that is what's happening right now. So North Carolina, through their Medicaid waiver, which is just a technical term to say they worked with the federal government to change something about their Medicaid program, but it has to be additional things that benefit Medicare beneficiaries. They wouldn't normally be allowed under the law, but we're going to go above and beyond and do that. And the broader transformation that is going to be starting next year includes what they're calling the Healthy Opportunities Pilots, which is quite honestly, a grand and quite exciting and amazing health policy experiment where in 2 to 3 regions of the state, they're going to have large entities of health payers. So, like your health insurers, like Blue Cross Blue Shield of North Carolina, they'll be contracting with clinical groups and human service and community-based organization groups in these 2 to 3 pilot regions to actually directly address and pay for 4 areas of social needs. So that includes housing insecurity, it includes food insecurity and nutrition, it includes interpersonal violence and toxic stress in the family, and it includes transportation that's health related. Though this will be the largest direct link between a Medicaid program and addressing social needs. So it's a really exciting moment. We have a grant with Robert Wood Johnson Foundation to work with the state of North Carolina and all these organizations that are managing this program and doing this program on the ground, as well as to bring together experts from other states and other commercial initiatives happening elsewhere in the United States, and academic experts and stakeholder organizations to bring everyone together to help us generate useful findings for this North Carolina program so that it can happen as best as it can. So I'll stop there, but just all to say, there are ways to achieve what you want within some of these broad policy levers, and sometimes it's just a matter of looking at, who is doing the interesting work that has interest to you and following that path. So I'll stop there and turn it over to Sarah.
Thanks. And Dana, actually, we'd love to hear from you. A little bit about your experience as a student and working with the center.
Hi everyone, I'm Dana and I'm an undergraduate. I'm currently a sophomore planning to declare a major in neuroscience and public policy and a minor in global health. So I'm part of the inaugural Margolis Scholars undergrad cohort this year, and I also interned at the Margolis Center this past summer. So I'm going to be sharing my perspective on those experiences so far. So over the summer, I worked with Dr. Dev Sangbhai and his team on projects related to COVID-19's impact on long-term care. So specifically, we were focusing on skilled nursing facilities within the Duke Hope Collaborative. So I was kind of doing work with both the Duke Health System and Margolis because there's a lot of overlap there. And I think that even though it was a very unprecedented virtual experience, I definitely got a lot out of the internship, especially even just having these virtual skills now that all jobs in school has been shifted in that way. And I had a lot of opportunities to connect with the other interns who are all really talented and had various interests, meet some Margolis faculty. And we also did some cool things, like we had a virtual visit to the WHO, which was really cool because that was kind of around the time that the US pulled out of the WHO. And then we got to hear kind of the global impact of that, which is really cool. And I've also been continuing my internship work throughout the fall semester, which is something that could possibly come out of the internship. If there are any other undergrads on here interested in doing that, it could turn into a more long-term thing. So I recently actually got IRB approval to complete a qualitative study as the lead student researcher, where I'm going to be interviewing some staff within skilled nursing facilities about the impact of isolation on residents. So in terms of their cognitive functioning and their physical functioning. And that's really cool. I'm very excited about that. And I've also been doing some additional work within the Population Health Management Office, which is the division of the health system that I was working with over the summer. And that's been related to telehealth and reducing hospital readmissions within the long-term care realm. So aside from those projects, I've also been working on a Margolis affiliated Bass Connections project over the fall semester. So there was a pop-up of COVID-19 themed Bass projects, and I applied to one of them and got in. So the one I've been working on is the impact of face coverings worn by providers on health outcomes in patients, specifically ages 60 plus with hearing loss. So still in this like geriatric space. And that's been really interesting so far. And I've gotten to meet a lot more faculty and other interested undergrads. So that's been really cool. And we kind of spent the fall semester in the development phase of the study, which is really nice also to kind of build the study from the ground up, since it was like a new pop-up theme And then moving into the spring, we'll be actually collecting and analyzing some data. Now I'm going to transition to my time as a Margolis Scholar, which has also been a really great experience. And even though, again, it's been virtual and different than past years, I think it's been like a really good connector to some other people at Duke, both undergrads and graduate students and faculty. So as part of that, I've been attending a lot of health policy journal clubs and skill labs where I've kind of gotten to just learn more about the current landscape of health policy as I'm kind of emerging in this space and learning about what's going on and trying to refine my interests. I think that's been really helpful. And I've also been able to connect with other scholars in one-on-one settings, and particularly with some graduate scholars that are in fields that I'm possibly interested in going into. So for example, I'm pretty sure at least that I'm pre-med. So I've gotten to have coffee with some med students in the program and learn about their experiences and how they plan to tie health policy into their careers, because that's something that I obviously am hoping to do. And it's just really helpful to have their guidance since they were in our places not very long ago. And then similarly, I've been able to utilize the Alumni Scholars Network, especially as I'm looking for some summer opportunities and not really sure where to begin. It's been really helpful to talk to people who are actively working in health policy and get some guidance there. And we also have advising through the Scholars Program, which is really useful since as I'm navigating a major and again, the summer opportunities, it's helpful to kind of talk out my short and long-term goals. So overall, I just think that both the internship and the Scholars Program have been really integral in kind of setting me up for my future path, both at Duke and beyond, because there's not really a structured health policy or public health major or program of study within Duke. So I've kind of been able to utilize the Margolis Center and the Scholars Program as my supplement to my academics, I guess you could say. And again, I've gotten to meet so many really interesting faculty and have been pulled into so many research projects and initiatives that I'm really grateful to be part of. And even the fact that I have an IRB approved study, I never thought that as a sophomore I'd really be doing that. So I would say if there are any undergrads here, I would definitely, if you're interested at all in health policy, just try to get involved in some way, because everybody here is very receptive to undergrads and very inclusive. And I feel like I'm just getting a lot of great experiences really early on. That's all.
Great, Dana. Thank you for sharing your unique perspective. So we would love to turn it over to you all for your questions for our panelists. So you can either drop, so if our panelists could come at least on screen so we can see you, and then we'll take your questions. So you can either raise your hand or drop it in the chat or just unmute yourself and start
talking. Hey, so my name is Josefa. I'm a current junior at Duke, and I actually had a question for Professor Boucher. I'm also interested in health policy, but I'm also pre-med, and I was interested in understanding how your transition from a more clinical setting to a more health policy or health administration setting, what that looked like, and was that like more planned on your part, or did it just kind of like happen as your career evolved?
Yeah, good. And I didn't really expound much upon my journey. I realized going first and then not having the opportunity to recoup. But now's an opportunity here with Q&A, and so we can draw out the examples. So I was a licensed PA for quite a while in Massachusetts and New York City, and so when I finished PA school in Boston at Northeastern University, I took a surgical and critical care residency at Montefiore Medical Center in the North Bronx. And so I did that program, got trained in surgical critical care, and then took a PA position in the south part of Manhattan at Beth Israel Medical Center, working in surgical critical care, operating on a 24/7 consult service, all run by PAs. and 2 ICUs, a step down, and a recovery room. After a few years, became chief PA for surgical critical care, and then chief PA in the Department of Surgery. And so I was overseeing 17 PAs doing 24-hour shifts for surgical consult service, critical care consult service, plus 3 ICUs, step down and recovery room, and a cardiac ICU. And so in that role, I oversaw quality improvement programs, staffing, healthcare delivery across a complex system of surgery and critical care. During that time, I also got an additional master's degree in public administration and focused in healthcare policy. And along different ways, managed quality improvement programs at Bellevue Hospital for inpatient hospice and palliative care, and then went to go run a PA program in Manhattan for about 3.5, 4 years before finishing my doctorate in public health. And so my leadership in healthcare administration spent a lot of time, overseeing stuff from a clinical standpoint, as well as a staffing and care delivery standpoint, and also had my hand in a variety of public health initiatives in the city of New York. And so it was a lot of clinically based administrative experience with a transition into starting to do research in healthcare delivery, specifically in palliative care and end-of-life care. So I don't know if that successfully evaded your question or not.
Yeah, it did. Thank you.
Okay.
Great. Who else has questions? Other questions? All right, so it looks like we have another one for you, Nathan. Bellis wants to know, what's been something interesting that you found in terms of how informal caregivers are affected by the work they do?
I think when we say informal, again, we're reiterating that it's not particularly trained or paid, but family or friends. And so in that vein, interesting things are the amount of squish that appears in their lives, schedule, emotions. They're just drawn every which way, and especially if you want to talk about those who are particularly squished as part of the sandwich generation, where they have younger kids, but they're also caring for aging parents or other family members. I think the resilience and the resourcefulness and the fact that they're able to swing their feet off the bed in the morning, whatever that hour might be, and actually stand upright and move throughout the day. I just find that to be the most fascinating thing. And as a parent of 2 young kids myself, with an aging mother, I definitely can feel that. So in terms of interesting, not interesting as in novel, but interesting as in mind-blowing, and recognizing people's resilience and being able to work with that in my research is pretty amazing. And frankly, it's a gift to be able to peer inside that.
Great, thanks, Nathan. Other questions? We have about another 15 minutes available for your questions. And if Jillian's still on, she can normally take 1 or 2 if you have questions about that. Anything she mentioned?
Sarah, are we able to volunteer?
Yes,
okay.
Absolutely.
Okay.
Open mic situation.
Okay, following what Nathan was saying, so I actually, as you may have seen in my bio, I not only work in the area of precision medicine. I mean, I work across a lot of topics, but my own work focuses on precision medicine, but I've also done a lot of work with caregivers as well. And even when I am doing work with precision medicine, I still keep in mind that caregivers are important stakeholders as well, just like patients, just like family caregivers, just like patients, just like the healthcare providers. and they're important stakeholders within healthcare systems and healthcare delivery. And to that end, I would say that the VA is also a fascinating place to work in the area of caregiver support. They have a national caregiver support program that's like a model for other systems within the U.S. and internationally. And Nathan and I together have been doing some work within the VA to basically make caregivers kind of more visible and integrated as actually part of healthcare teams. And I don't know if you have questions about that, we can elaborate on it. But I would just reiterate basically what I was saying in my talk, which is that the VA is a really interesting system to look at programs that can really help to bring about like wider, like shift basically norms, including with caregiver support.
Great, Nina, for expanding upon that. We do have another question that's come into the chat for the entire panel, wondering what are the areas of health policy or, of healthcare and health policy do you see undergoing the biggest transformation today, and what initiatives excite you the most?
I can take a crack at that one. I think it's relevant to what some of the work that I'm doing. I would say there's two answers to that question. One would be what is referred to as the value-based care transformation. So the Affordable Care Act really started this, although the ideas have been around before then. And today, as one example, one single value-based care program called the Accountable Care Organization Model, again, started by the ACA and through Medicare, but also has been expanded by commercial payers and in Medicaid. Right now, about 14% of the US population is in an accountable care organization model. If you go back 10 years, that was basically 0%. So that's a pretty big shift for the, for a decade of the US health system, which has tended to move kind of slowly. Those types of organizations, and just to explain what I mean by that, it's a legal mechanism where a whole group of doctors, hospitals, and other clinicians they form a legal entity where they're jointly responsible for the cost and quality of a group of patients that seeks them for care. So they have to work together, the theory being that care coordination and care transition management is really important. They have to report on and meet high levels of quality standards, and then they have to work within what they call benchmarks, which is kind of like a patient level budget, where they look at the end of the year, or sometimes they tell you at the beginning of the year, they see how much you spent per patient on average. And if it's too much over a certain amount, then you sometimes actually have to pay back some of that money to the government or to the payer, depending on the contract. And then if you, on the other side, if you were able to hit these high quality metrics, but you spent less than they were looking you at, then they were sort of, aiming for you to spend, then they'll give you part of that money back and you can use it to invest in your own program. So that sort of model, and that extends beyond accountable care organizations, is still, expanding. And now you're, again, 1 in 7 people are in that model. The second part would be what I was talking about before, and this is through this value-based care transformation. But, for many decades, the human services sectors have been trying to get, and public health, additional funding for their services. In the United States, we've chronically underfunded a lot of areas of the social safety net, which is very unfortunate. And there's not really a great excuse why that hasn't passed legislatively, but in the past, 5 years or so, there's been political windows of opportunity to do that through the health system. There's debates on whether or not, that's the ideal way to do it or the most efficient way to do it, but at the same time, it is the policy opportunity. So you're seeing a lot of interesting things like what I was talking about in North Carolina, the Healthy Opportunities pilots, where there is a new legal and regulatory authority for the health system to do things like paying for meal delivery for Medicaid populations that are marginalized, paying for transportation to doctor's appointments, paying for counseling for toxic stress, et cetera, et cetera. And the net can be wider or narrower depending on who you're talking to. But that sort of addressing social needs through the health system, I think, is a really exciting and hot topic right now. So I'll stop there.
I'll add, this is Nina, I'll add that just generally, I think use of big data sources, making use of data from the EHR, like I said, through really advanced clinical decision support models that use machine learning, or it's actually artificial intelligence. I think that's like a really big transformation, and we're really at the cusp of that right now.
I could also add that I think that, especially in the past year, there's been a lot of light shed on a lot of systemic inequalities within the healthcare system, and there's been a lot of research and initiatives focusing on that, even the Margolis mission statement changing to reflect a bigger focus on health equity. So as we all know, with COVID-19, those disparate outcomes have been really highlighted. So I think that that's also something going into the next few years that's going to be more focused on. And also, again, on the COVID-19 theme, a lot of telehealth and telemedicine, more development in that space. So personally, working with the Population Health Management Office, what they're doing right now is organizing a team of pharmacists, hospitalists, other clinicians, nurses that meet on a weekly basis to discuss patients one by one and try to kind of collaborate together and virtually meet to try to reduce the risk of readmission of a long-term care resident into the hospital. So those are some meetings that I sit in on and I have seen be really effective. And also just telemedicine visits in general have been really efficient. And in terms of access, it both can expand it if you have the technology, but then it could create other problems if not. But that's a whole other topic of conversation. But yeah, I just wanted to add those things.
Thanks, Dana, for your contributions. So we have a couple more questions that have come in through the chat. We have one from Melissa, and Will, you may be able to speak to some of this. I'm not sure how familiar you are with Christina and Marianne's work, but I think they might be some people who can help the student. So from Melissa, she says she's headed to Fuqua next year, and she works in antibiotics and is curious about any work that the center is doing in this area in terms of like reimbursement policy around antibiotics.
Yeah, I can take a quick stab at that. We actually are looking to hire some folks in that exact area. I believe the position that's listed is Antimicrobial Resistance, AMR. So, a senior staff member who would be managing a portfolio of research on that. We've done a little bit of work on that recently. One of our senior staff members who just made the jump to industry very recently, Monica Schneider, was developing some work on innovative payment for antimicrobial resistance. So it's definitely something that has gotten to the level of a job posting. So I would say stay tuned. I don't know if Jillian, I don't think Jillian's still on. She might have had more to answer, but yeah.
Yeah, she's not. So Melissa, maybe you can follow up with myself and Will offline, and we'll try to keep you connected as things transition here at the center. So we have one more question in the chat from Megan. Sorry, there's a couple coming in. So it says, for panelists who have done research in the VA, I've recently become interested in health policy, and I'm wondering what exactly health policy research looks like in the VA, and also wondering if any research is being done at the VA about medical literacy of patients and caregivers, as well as physician bias at the VA. So Nina, this might be your realm.
Okay. I was hoping Nathan would take that. So
happy to jump in. I'm happy.
Okay, great.
Well, I'll just say again, like the health policy research in the VA, like there is this. Basically, I think it follows a pattern in that there are like national initiatives, national mandates that get rolled out really fast. And then a lot of work needs to be done to figure out how to implement it, and actually at the local levels and regional levels where the rubber hits the road. And it, it's messy, but to me as a researcher, it's fascinating. So that's like, I think, a big point. And then as far as like the medical literacy of patients and caregivers, I mean, yeah, so there is a lot of work done with regard to health literacy. I'm not sure for caregivers, but yeah, I'm sure that there is that work. I don't know of anything specifically off the top of my head. I also going back to my first question about what health policy research looks like. I'll also add that the VA, like, is very susceptible to like political, whatever political influences. So things can happen really fast, for better or worse. And so you just don't always really have a lot of control as well over, what happens. So like, as an example, I was evaluating part of a team to evaluate rollout of a national long-term care program that was purchased by VA and implemented in community settings. And it's, by all accounts, like a really good program, but a lot of the local VAs that were actually running the program and hiring community-based providers to deliver it were relying on some dollars that were part of a certain legislative act, and then there was a budget stalemate, years ago, and the money was frozen, and then that caused a huge problem, and then the program wasn't really actually able to be rolled out nationally in a coordinated way like was expected, and then that affected our study design. And so at the end of the day, as an implementation researcher, I was able to roll with it, but the folks who were looking to do a more like randomized study that was part of the rollout. We were going to do it in a staggered way and looking at outcomes. They weren't able to actually follow through. They had to completely change what they were doing. So that could be frustrating. I don't know if that made sense, but so Nathan, did you want to add anything?
Oh, the bureaucracy, but also the innovation. I mean, I see the VA funding projects that the NIH would never think about doing, like a spiritual assessment tool. And so, it's actually a great lab to try things out in the VA system. I want to caution a lot of health policy oriented folks who think you want to go that direction, is that health policy exists on both micro and macro levels. People think that if I'm an aide to a congressperson, then I'm doing healthcare policy. Well, very few people actually do that. Healthcare policy works over at Duke Medical Center, where somebody's trying to oversee the policy of a unit or a department. So healthcare policy works on a variety of levels. And so I always encourage students to think broadly about that. It doesn't mean you're beating the halls of Congress and speaking with legislatures necessarily. It could exist at the local as well as the regional and state and national levels. So try to think of it that way too for opportunities in health policy.
Great, thanks, Nathan. And we have one more question, time for one more question, and which came through into the chat to Nina. So, regarding your work on clinical decision tools, are the tools developed at Duke or by an outside company? And what have been the greatest barriers to implementing or adopting IA or ML tools, especially into the healthcare workflows?
Yeah, thanks. You may have heard me typing because I wasn't sure if I'd be able to get the answer. So so both in-house, they're developed both in-house and by other companies. And actually, I'm starting to get involved with some work to see, that has implications. I mean, it may be that, in some systems that the off-the-shelf tools won't be as good for what they need as those built in-house, but not every system has the capability of building things in-house. So I know you're asking about Duke specifically, but I'm just saying that's a really good question in general. But Duke uses both, and they're looking to see, does it like matter really? And the greatest barrier, I think, for implementation adoption is by far alert fatigue. And that doesn't just have to do with AI ML tools. It can also be just like regular rules-based alerts, but it does affect adoption of AI ML tools if people are just getting all kinds of alerts and they're not necessarily value added. It causes them to not actually pay attention. So that's something that we're looking into as well. And then I think another barrier is kind of probably underlying that is this chasm between the developers of the models and the end users. And so we're trying to do some work to kind of bring them together and have them basically like co-design and think about implementation early on, from the time that the algorithms are kind of being designed and thought of, because it's not just about the technology, it's also about how does it fit with the workflow and what is the value add there. I hope that answers your question.
Thanks, Nina. And thank you everyone for to all of our panelists for answering questions. I want to spend a few minutes now to just talk about some ways that you can engage with Duke-Margolis in the future. Okay, so for those of you who are either currently at Duke or on your way to Duke, we have what's called the Duke-Margolis Seminars in Health Policy, which aim to connect the Duke-wide health policy community and to help people form, develop, and shape their health policy related work. So most seminars that we offer cover research or policy analysis that's in progress, while other presentations include, include presentations by faculty, staff, or visitors on significantly newly released research or legislation. So if you're not affiliated with the Duke community, note that we do host some public workshops and webinars that are frequently, and information can be found on our website. For those of you who are coming in as students or at the undergraduate or graduate level, we do have the Margolis Scholars Program. It is a prestigious program for Duke students that demonstrate a strong interest and commitment to a career in health policy and management, as well as leadership potential to improve health policy. So the program provides promising students with the necessary skills, knowledge, and abilities to be the next generation of health policy leaders. So the program has 4 components, so knowledge building, skills enhancement, training and professional development, and community building and networking. And these activities are offered across 4 components. Things like health policy course related work, skills lab, planning policy events, and also receiving one-on-one professional advising and mentorship. So in terms, sorry, let me get these up here. So in terms of important things to know about, if you're planning to apply, currently for our undergraduate students, the application is now open. You'll need to complete an online application as well as submit your recent transcripts and resume, and also give us some information on a professional reference. In terms of if you are, applications for medical students are open on March 1st and April 1st for all incoming non-medical graduate students. Okay. We also have a summer internship program, which is open to Duke and non-Duke students. It's a unique program as interns gain professional experience in the field of health policy while also developing strong networking and mentoring relationships. This is done through the mentorship component of our program, where the interns are matched with a mentor or research team, and they work on research projects directly over the course of 10 weeks over the summer. As a culminating experience, interns complete deliverables on their research projects. So there's a research poster presentation as well as an oral presentation and some sort of video or reflective blog. But throughout the summer, we also have other activities to help further the interns' understanding of the field. So while also developing their professional skills, in the research symposium, we also have the seminars, we have discussions on anti-racism and journal clubs, as well as social events. So the application for, okay, let me get these. Sorry, let me go back one. So our internship application opens in just a few days. The application opens on the 14th and will run through January 31st. And then, as Dana mentioned, we also have some BASS Connections projects. So the center has applied and been accepted for a multitude of BASS Connections projects through the university. So these projects assist to bridge the gap of the classroom and the real world, giving students the opportunity to, a chance to roll up their sleeves and really kind of tackle these complex societal problems alongside faculty and staff on interdisciplinary teams. And these are actually taken for course credit. And here's a list of just a couple of projects that we have going on. Also, as Dana mentioned, we have currently a specific theme that we're working on this year. And some of these projects will go into next year as well. Related to the COVID-19 pandemic. And so these research teams are making unique contributions towards responding to the current pandemic, and also as well as hoping to mitigate future ones. Oh, sorry, I guess I clicked too far on that one. Sorry about that, you guys. But here's a list, and they can also be found on our website. All right. Also, so we are also starting to offer some health policy concentrations across different programs at Duke. One that we have that launches in the fall of 2021 is a health policy concentration in the Masters of Science in Population Health Sciences degree program. Our health policy concentration aims to empower students with the skills that are required to design, implement, and evaluate healthcare and health policies at the local, state, and national level, as well as to advocate and lead changes. And throughout the next, 2021 and 2022, we'll be adding different concentrations and different programs across the university. We do also have a partnership with the Student Collaborative on Health Policy, also known as SCOPE. It's a student group at Duke that works with us closely. Their mission is to unite students across disciplines in the university in a collaborative effort to increase awareness and opportunities in health policy through a focus of 4 domains. So they focus on campus engagement, career and professional development, health policy, education, and service and advocacy. Currently, they have approximately 80 active members. Be sure to follow them on social media, as well as get involved with them when you choose to come to Duke. Okay. So does anyone have, I've got time for 1, maybe 2 questions about any of our programming. Okay, well, great. Well, I want to thank you. This kind of brings us to the end of our open house. I want to thank you to our wonderful panelists, and thank you to all of you for joining and engaging with us this afternoon. Please stay connected with us and get updates on everything that goes on in our center by subscribing to our newsletter or following us on social media. Thank you all so much. Have a great day and a great weekend. Appreciate it.